Well, it's 7 o'clock. We'll use the behavioral theory that we reward the good behavior and ignore the bad behavior of people that couldn't get here on time. And welcome you to the Oneida Public Library. Focus on opioids in Oneida. And library staff and the folks from Bridges and the Central Region Addiction Resource Center have put together a distinguished panel who will help to define the nature of the problem here in Oneida and some more broadly in Madison County, at least in some contexts. We're going to ask each of the panel members to give a introductory comments, observations, information, and then we will open it up for questions and answers, or even more discussion and dialogue as needed. Also, just to let you know, in the audience today, we have Madison County Sheriff Todd Hood, who is joining us and is available as a resource. We have Brian Decker from Family Counseling Services, which is an outpatient treatment program right here in Oneida, and they also have offices in Madison, Portland, and at least several other places beyond that. And then also joining us is representative from Senator Gillespie's office, Tracy Carmen. I'm sorry, I apologize for that. So I think what I'll do is probably just briefly introduce each of the panelists, and then we'll get going. We'll probably start with you, Eric, after we do the brief introductions. And oh no, we've got word from.
Oh, please introduce your panel.
Representative Tenney. So, but first was the Madison County's Public Health Director, Eric Keist. And next to Eric is a person that I've known and worked with for over 40 years, although she was in grade school when she started. Is Susan Jenkins, who is the Executive Director for Bridges, and Judge the Honorable Dennis McDermott, who I've known since childhood as well, unfortunately. Who is in Madison County.
The intermittently honorable.
Who is a Madison County Court Judge, and he's also the judge for Madison County's Family Treatment Court, and one other aspect of it that wouldn't appear publicly, in his role as a county court judge, he makes multiple referrals into the criminal treatment court as well. So he's got some insight on both the family treatment court and the criminal treatment court as well. Next we have Jim Strail, who is the program director for Maxwell House, operated by Liberty Resources. And we have Chief Paul Thompson, Chief of Police here in Oneida. First came to Oneida as a police officer in 1989, and now is back with us as the chief. And finally, an excellent budding tennis player, which is Dr. Ofana Reed, and somebody that I've also had the opportunity to work with, who is the Chief of Medicine, or Chief of Medical Services?
Chief Medical Officer.
Chief Medical Officer, I apologize for not getting that right, Dr. Reed, with Oneida Healthcare. So we have a very distinguished and broad panel, and we're very excited to hear what they have to say tonight. Next, let me introduce Colleen, the library staff, who's going to give us a little word from our representative, Claudia Tenney.
Hi, I'm Congresswoman Claudia Tenney, and I'm sorry I could not be there in person. Every day in America, more than 144 Americans die of an overdose. Locally, in Oneida County, we lost 38 people who died of drug overdoses involving opioids. Across the 8 counties in the 22nd Congressional District, there were 114 opioid deaths last year, which, excluding New York City, accounts for almost 10% of the total opioid deaths statewide. There were also 191 hospitalizations and a staggering 672 emergency room visits by patients who are experiencing an overdose. Last week and continuing into this week, Congress will take up more than 20 bills to combat the opioid addiction. My bill, the Expanding Oversight of Opioid Prescribing and Payment Act of 2018, will be voted on this week. This bipartisan legislation requires the Medicare Payment Advisory Commission to evaluate and report on adverse incentives that lead to the overprescription of opioids and underutilization of non-opioid alternatives for post-surgery recovery and the treatment of chronic pain. I will continue to work with law enforcement, healthcare professionals, stakeholders, and families to ensure we are effectively combating this epidemic. There's a reason to hope in the future, and it is with help from people just like you that our office can continue our efforts to fight back. Thank you for inviting me, and I hope all of you will not hesitate to reach out to our office if we can be of further assistance.
And with that, let me turn it over to the Director of Public Health, Bill Cuddy.
How much time did we have? Because she just stole most of my stuff. So, anyway, I'm Eric Feisty with the Director of Public Health for Madison County. Thank you all for being here this evening, and thank you for allowing me to present as well on this important topic. Being from the Public Health Department, I'm going to throw some statistics at you, which you've already heard some of them. More geared towards Madison County. I don't have the specific data for Oneida, or the city of Oneida, but the trends that we see in Madison County mirror those nationally and statewide, so this discussion will be similar. As she indicated, overdose deaths in Madison County continue to rise each and every year. In 2008, we had 2 deaths. In 2016, you had 14. That's about a 600% increase over that time frame. Overdose deaths for prescription opioid cures of men and women equally in Madison County. It's about a 50-50 split of who dies from opiates. Tends to be predominantly individuals between the ages of 25 and 44. And also among those who have a high school education or less. Except for the use of heroin, where we see heroin overdose deaths. That's predominantly, we see that in men in Madison County. About 3 out of every 4 deaths occur among the young men. Madison County also has the dubious distinction of having one of the higher rates of prescribing opiates in the central New York region, and in comparison to the state as well. The last few years, we've seen a growing number of deaths associated with heroin overdose. Previously it was more prescription-based opiates, but we're seeing more heroin overdose deaths, and just recently we're now seeing increased number of deaths due to fentanyl, which is a synthetic opioid that's 50 to 100 times stronger than heroin. And then unfortunately, Madison County has the dubious distinction also of having one of the highest rates among counties of overdose deaths due to fentanyl as well. Now, this meeting is an example. We know that this issue is affecting our community in many ways, and all facets of our community. From economics, where we're seeing increase in healthcare costs, we're seeing costs in addiction treatment, we're seeing lost productivity at work. People can't go to work, and just criminal justice involvement costs as well. As was mentioned in Ms. Tenney's conversation there, we are seeing an increase in hospitalizations and emergency room visits that continuously increases at a dramatic rate in Madison County. We also see an increase in treatment program admissions among Madison County residents, and as well as an increase in crime and related opioid types of arrests. In addition to the economic costs, we also see social and other associated health costs, such as neonatal abstinence syndrome, which occurs in babies whose mothers use opioids during pregnancy. They go through withdrawal symptoms, as well as we're seeing an increase in the number of children who are being placed in child protective services as a result of heroin, opiate-related abuse and neglect. Try and check in my notes. Too much data. In regards to the child protective services, between 2014 and 2016, we saw a 50% increase in the number of kids that were played. There were a number of petitions that were filed for child abuse and neglect. But fortunately, in 2017, we saw a 50% decrease in the number of petitions. So that's a good trend. That's one of the good things that we are seeing here. But this isn't really a new epidemic, if you will, even though it's been declared a national public health emergency in 2017. This has been a growing epidemic for the last 20 plus years. And one of the main underlying reasons for the causes of this has been the increased acceptance and use of prescription opiates for treatment of pain management, despite serious risk and a lack of evidence to support the long-term effects of treatment. And a key factor to this has been the pharmaceutical companies' claims that these drugs were safe and non-addictive, and coupling that also with, as Congressman Tenney indicated, incentivizing providers to use them, which here sounds like her bill's going after that type of activity. Another factor that maybe Dr. Reed can speak to a little bit more is we also saw around the same time that pain had become a vital sign for clinical care. Unlike other vital signs like blood pressure that can be measured, there is no objective measurement for pain. In fact, pain levels is determined by the patient and not by the provider. We also see high daily risk factors, high daily doses of opioids being taken by individuals. A lot of this had to do with, it's not as much of an issue now, but a lot of this had to do with people getting multiple prescriptions from different providers, getting painkillers from a doctor for a back injury, and at the same, go to the dentist 2 weeks later, get a tooth pulled, and you get a painkiller there. And there was no kind of coordination of those prescriptions amongst providers. There's more improvement in that area. You know, providers used to prescribe, it's very common to get a 30-day supply of painkillers. But we know that after 7 days of usage, you have significantly higher risk of becoming addicted, and yet you have a 30-day supply. So, at a national level, we are seeing the prescribing of opiates starting to level off and decrease in some instances. However, we're still seeing opiates prescribed 3 times higher than we were seeing in 1999. So reducing the misuse of prescription opiates is still a critical prevention strategy for us here in Madison County and elsewhere. We also see that, you know, when individuals are done with their care and or they run out of their prescriptions, they only have a couple options if they're addicted and what they can do. You may see them start to steal prescription medications from other people's medicine cabinets, friends and families and so forth, or they turn to more of the illegal drugs, the heroin and fentanyl, which are pure, cheaper, and in the case of fentanyl, 50 to 100 times stronger. So unfortunately, and ironically, I guess, prescription opioids are actually a risk factor for heroin use. In fact, 4 out of every 5 heroin users misused prescription opiates first before they became heroin users. So in Madison County, we are doing things. We may not see that overtly, but just going to give you a few examples. In the end of 2016, the Madison County Opioid Task Force was established. There's several individuals here in this room that were part of that task force. And the purpose of that task force was to identify and implement initiatives that incorporated prevention, recovery, treatment, and enforcement activities with the overarching goal to reduce opioid overdose and abuse. And the task force, since the end of 2016, has engaged and launched several initiatives, including working with providers to minimize the prescribing of opiates for pain management, providing public education and outreach on safe disposal, safe storage of drugs, prescription opiates, improving surveillance and data collection, treating people for opioid use disorder, and improving access to naloxone. One of our things that our health department does, and there's copies up here if you want that, we produce an annual report on the opioid situation here in Madison County. It's local data, Madison County data. It doesn't get much local than that. And in here we also have a lot more of the data that have gone over, and as well as a lot more of the initiatives that have taken place in Madison County. And if I went further than we're supposed to, so I'll conclude my remarks.
Thank you very much, Eric. And next, Susan Jenkins, Executive Director of Work Business.
So we are legally the Madison County Council on Alcoholism and Substance Abuse, and we've been around for about 30 years now. And I think Eric covered a lot of what we're seeing in Madison County. And so I guess I would speak to some of the things that we're doing, looking more at maybe some of the solutions that we've tried to implement here. So we provide information referral to families or individuals who are struggling with addiction of any kind, because sometimes people are at their wits' end. They don't know what to do, who to call, and they will come in and concerned about their own use, but more often concerned about someone that they love. And we can meet with them and talk with them about what's going on, and then point them in the direction of what would be the most appropriate level of care, looking at their insurance. And oftentimes we connect with a lot of the other providers in this room. So it's kind of a place where people can start if they just don't know where to start, who to talk to, and it is confidential and it's free, so that's always nice. And indeed, we do see many people struggling with both opiates as well as heroin and all the other drugs that are available in Oneida and in Madison County. And at times they come in and they're in tough shape, and so we need to get them sometimes to detox or to a hospital first. But it really depends on what level they're at, what kind of referral we make. But that's one of the things. And we certainly see families, and that's the other support that's needed, families who have an adult child with a problem, either taking care of their grandchildren because their children are in jail or their children are no longer able to care, kind of Eric alluded to the kids in foster care. So providing support to grandparents as they are raising their grandchildren, which they didn't expect to do. Or just providing support to people wondering, what do I do? This person I love just will not get help. Well, can you make them get help? And so, what can we do? As Eric said, this problem is not new. In 2009, I remember we had a town hall meeting, and it was a packed auditorium, and it was about prescription misuse. And from that meeting, with a lot of representatives from some of the same groups here, we started with the kiosk. So we look at prevention by and large, and certainly in terms of educating providers about prescribing, but also when you survey young people or others and talk about where they got their medication, they go rifling through people's medicine cabinets, whether it's a babysitting job, an open house for a realty company, friends and family, and sometimes people get medication, especially if they're going through some major health issues, that's delivered to their house in big boxes. So we, through many efforts of many people in this room, kiosks were established, 2 in Wampsville, one at DSS, one at DMV. There's a kiosk at the State Troopers, which is 24 hours. There's one in the Chittenango Police Department. There's one now at the Hamilton Hospital, and there should be one soon at the Hamilton Police Department, as well as 2 collection events that take place in the landfill in the spring and the fall, as a way of saying, just grab whatever medication, bring it with you, and I mean, I'm up there myself, big bags. We have a deputy who's there to oversee the process, and people bring in literally bags and bags of medication that is now out of the medicine cabinet, off the floor in Grandma's bedroom, and safely disposed of. So I think in terms of prevention, it's an effort that is very well supported in Madison County. There have also been some collection events at Clear Path for Veterans and also at the Hamilton Public Library. So I think many people recognize this as one way of helping to get some of these medications off the street. We also, as was mentioned, I'm not going to go into a long, there's a pamphlet here. We got a 5-year grant from the Office of Alcoholism and Substance Abuse Services to coordinate the Central Region Addiction Resource Center. And although the money came from opiate money, it really looks at all addictions, and it covers Madison County, Cayuga County, Onondaga County, Oswego County, what am I missing? Portland. And basically each county can provide their own services. It's about prevention, treatment, and recovery. It's about support services, peer support, and they can apply for mini grants. So some people, there's Sober Saturdays taking place in one county. They've had community education events. They've had speaker events. They've had some open houses at schools, trying to get as much information out to people, kind of like we're doing tonight, about the scope of the issue and what can be done. So I'll cease now. But if you have any questions, I will stay, and certainly, I'm sure we'll be taking questions. Thank you for your attention and for inviting me.
Next, we have the Honorable Dennis K. McDermott.
Well, I preside in county level courts. There are two of us, Judge Patrick O'Sullivan and I are the two county level judges. And we sit in county court and family court. We also do surrogates court, but that really doesn't have much application to the opioid crisis, of course, until it's too late. In county court, these are the criminal cases, and these are felony level criminal cases. Lesser crimes, misdemeanors, for example, are treated in the local courts like city court or the various town and village courts around the county. But in Madison County, in a typical year, we will have between 200 and 250 felony level cases. This year, I would say, I just got an indictment on the 14th, that's case number 110. So I'd say we're probably on track to hit about 240 felony level cases in Madison County this year. Of the 240, I would estimate at least a third are drug or drug-related felonies. And by that I mean, if not possession and sale of some illegal drug, then some type of illegal activity engaged in by somebody who's looking to support his drug habit. This could be burglarizing your home, breaking into your car, stealing your property, possession of stolen property. It can be possession of a forged instrument, where they take a prescription they got from a doctor, and in the little panel where it says how many refills you get to have, they have some people who, believe it or not, will actually put a glob of white out, like the pharmacist isn't going to figure this out, and write in 70. So they get nabbed pretty quickly. But that's the felony level types of cases and the number we get. I don't have any statistics as to how many of those come specifically from the city of Oneida, although I'm sorry, Chief Thompson's got a much better handle on that than I do. And then in family court, these types of things will manifest themselves in child neglect cases. And child neglect cases generally fall into one of three categories. It's either the filthy house, it's domestic violence, or it's alcohol and substance abuse. And sometimes that alcohol and substance abuse marries up to domestic violence, so you get a double whammy. Of those cases, I would say probably we get probably about 40 or so neglect cases in the course of a year, and I would say at least half involve alcohol or drug abuse. I couldn't separate alcohol from drugs, and I don't have those statistics available for you. And of that half, I would say half of that probably involves opiates, or at least half of that, maybe more than half. Now, the programs we have available through the courts in Madison County, we have two. One operates out of family court, one operates out of the criminal courts. In family court, beginning in 2005, we were one of the 62 counties in New York State that began what they call a drug court. And in our county, we call it the Family Treatment Program. It's not a separate court from family court. It operates out of family court. I'm the judge that handles that. We have a CASE Act, a Certified Alcohol and Substance Abuse Counselor, Dawn Krugingers, who is Rick's wife. And Dawn really is the brains behind the operation. She's the one who knows what she's doing. I'm more of a figurehead, so-called pretty face that comes out. But since its inception in 2005, we have had 271 referrals to our family treatment program. Of that number, and I should mention, of the 271, 30 of those came last year in 2017. Of the total referrals, we have 89 who have been accepted into the program, 40 who graduated. Now, when I say graduated, I have to put a bit of an asterisk after that. There have been 2 who post-graduation relapsed and came back in again. We'll never slam the door shut in anybody's face, but just because they graduated doesn't mean it's the last time we're going to see them. You have to apply to be into the program. You come to court every 2 weeks. You are subject to random drug screens. What I do not do is I do not incarcerate anybody if they relapse, not in family court. but it can get them expelled from the program. And the consequence for that is they're now back out in the cold. They have to try to cure themselves because if they can't get their kids back, they stand a real chance of having their parental rights terminated. We're not going to have kids go back to their parents if it isn't safe or proper for them to do that. Now, in the criminal context, in 2009, the state legislature created a thing called the Judicial Diversion Program. This is available to people who are charged with certain types of crimes. Typically, they're drug or drug-related. There are certain crimes you're just not eligible for. Crimes of violence, for example, would not be eligible for this. But the idea is, if you are accepted into the program, they start you out with, you plead to whatever you're charged with, and you go on interim probation supervision for a year or two. And if you are successful, and it's the same, very similar to the family treatment program, where you're subject to random drug screens, and you have to show up every 2 weeks and things like that. Many referrals to family counseling service. But depending on how you do, at the end of your participation in the program, you're allowed to withdraw your plea to that more serious crime, typically a felony, plead to something lesser, like a misdemeanor, and get a much more lenient sentence. So that's the carrot at the end of the stick. Now, Dawn Kubiars also runs that program, and she tells me that there have been 239 people who have applied for participation in that program. 103 have been accepted, and unfortunately, they have had 4 who have died, either during participation or after completion. So we have lost some people. Now, that's what we have available in Madison County. If we sentence somebody to state prison, there are 3 programs that are potentially available to them there. I should mention that if they're going to state prison, they have to be sentenced to more than a year. If the sentence is 1 year or less, they become a guest of Sheriff Wood. But if it's a year or more, the programs we have available to them are 3. One is called CASAT, C-A-S-A-T. It stands for Comprehensive Alcohol and Substance Abuse Treatment. We can only order somebody into the CASAT program if they've been convicted of a drug offense. They can be eligible for other types of offenses if they're somehow drug-related, but it's nothing that I can order DOCS, which is the Department of Corrections and Community Supervision. I can't order DOCS to accept them. On those cases where I can order them into CASAT, it's only CASAT Phase 1, and this is a 3-step program. The Phase 1 takes place during the last 6 months of their incarceration. Phase 2, they have to apply for it. DOCS has to accept them. It's a step-down program to a community house, very much like possibly Maxwell House. And then Phase 3 is out of the community house and into the community, full-time. So that's CASAT. There is also a program called Willard. This is a former psychiatric hospital, now a state prison in Willard, New York, which is outside of Romulus on the east shore of Seneca Lake. This is a boot camp. I can only order people into Willard, again, if they've been convicted of a drug offense. It's not for people who have alcohol problems. It's not for anybody else. I can only order them in if it's a drug offense. They cannot ever have had a violent felony conviction in their past. Willard will not accept it if they've had it. But it's a boot camp. It's 90 days. 90 of the most miserable days you will ever spend in your life. I've been on a tour of Willard twice in the last 17 years. I come away from it very impressed with it. There are corrections officers who are going to be in your face every waking minute of the day for 90 days. The idea is, if you successfully complete Willard, you spend the rest of your sentence on parole supervision. If you trip up, if you don't complete Willard, say you bail out on the 89th day, you get to start all over again. And you keep cycling through until you finally complete the 90 days where your sentence runs out, whichever comes first. I would say almost the polar opposite of that is the shock incarceration program. There are 2 shock facilities in New York State. One is called Mariah. It's outside of Lake Placid. The other one is called Lakeview. It's out in the Fredonia, Dunkirk area. The idea there is this is a 6-month program. Again, I can only order somebody into shock if they've been convicted of a drug offense. If they have not, they can apply for admission to shock, and then it's up to docs whether they accept it. Because there is a physical component to this, they're up running 5 miles a morning at 5:30 in the morning every single day for the 6 months. They will not accept anybody who is 50 years of age or older into docs. Also, you cannot ever have had a violent felony in your past. And unlike Willard, where if you mess up, you get to start all over again, in shock, if you mess up, you go to general population. Some other, Elmira, Auburn, Wendy, any one of those 5 points will take you in at that point. So that is the shock program, and again, as I said, that is 6 months. I had a tour of the Moriah Shock Facility in July of 2013. I had gone up to see Dana Mora in the morning, and then Moriah in the afternoon. It's kind of the alpha and omega of the criminal justice system. It's a minimum security prison. There is no wall, there's no fence. And we had a prison in Madison County very much like that, called Camp Georgetown. They closed it about 5 years ago or so. No wall, no fence. And I had a tour of that also. So I asked the superintendent at Moriah, you ever have anybody that just walks away and leaves? He said, nope, and I'll tell you why. Unlike all the other prisons, where inmates come in one at a time and you never know when they're coming in, with shock, they come in one class at a time. They come in by bus. And once a month, every month for 6 months, a new class comes in, all the other classes move up one rung on the ladder. So there's a new class coming in. He said, we have them on a bus. We have them get off the Northway about 3 exits south of here. And we have a special route we take them on. We drive them to the woods for about a half hour, and they don't see anything that looks anything like civilization. We bring them in the back gate, where there's a sign that says main gate. And their first night in, we bring them out after dinner onto the parade ground. We have them stand at parade rest just at about sunset. So we don't have to wait more than about 30 seconds. You hear that first coyote about 1 mile over. And then another one will answer it, and their eyes get as big as saucers. And we tell them, and in addition to coyotes, we got bobcats, and we got snakes out there. So if you leave us, you're not going to be alone long. He said a lot of the guys from the city think deer have teeth. He said the other thing is, it makes those morning runs very competitive. The thing I want to conclude with is, a lot of people wonder, well, what is the criminal justice system doing about this? There was a case was decided in, there's an intermediate appellate court called the Appellate Division. And this was the Appellate Division down in New York City. They decided the case last November. This is a Dr. Lee, L.I., Dr. Lee, who was a pain management specialist who opened up a clinic in Queens, which according to the court was nothing more than a pill mill. According to the court, appointments were not necessary. All payments were in cash. Typical visit would cost $100, but patients who came back earlier than a month later for their next month's prescription, who obtained prescriptions from other doctors or who needed more than three prescriptions or prescriptions for more than 60 milligrams per day, were charged an extra $50. Over the course of time between 2008 and October 2011, this doctor wrote over 21,000 prescriptions. Okay, and he would typically take the $100, and it was cash. $100 cash, don't bother with your insurance company, cash, and the cash would go right into his pocket at the appointment. This doctor had 2 of his patients die. One of them, his body contained 20 times what would be considered a therapeutic amount of oxycodone, a fatal dose. And the other one, while he didn't have an excessive amount in his system, it nevertheless caused his respiration system to shut down. This doctor was convicted of reckless manslaughter in both cases, and sentenced to a term, an aggregate term between 10 and 20 years. The Appellate Division confirmed that. They affirmed it, I should say. Could go up to the Court of Appeals, you never know. But, trust me when I tell you, prosecutors around New York State are very well aware of that case, and will probably be using it as precedent. So that's pretty much my remarks.
Thank you very much. Next we have Jim Steele from Maxwell House. Jim?
Thank you for having me here tonight. It's definitely a pleasure. A little rundown after a long day, so I'm a little on the fatigue side. But anyways, it's great to be in Oneida. You know, I worked in Oneida for a few years. I worked for Family Counseling Services, and previously I worked in Cortland. And after working with Family Counseling Services, I worked in Conifer Park in Liverpool for a couple of years, and then the opportunity came up to come back here. And I remember whether it was Cortland first with Family Counseling or here in Oneida with Family Counseling, there was always like kind of an element of the small town that I always enjoyed working with, because it was the problem was something where you were able to see it, you were able to combat it, and it wasn't something that seemed to be out of control yet. You know, I know that sometimes when you get a little closer to the city, sometimes you can where are we supposed to start with this? It's a wild thing, and we don't even know where to start. But you know, being back in Oneida is fantastic. I do like to be in the small town environment. But I don't think there's really any small town that is not being touched by this right now. I think we're all pretty aware of exactly what's going on and how significant it is just by some of the stats we're hearing. I don't have many stats like that off the top of my head. I'd like to be a stat guy like that, but I don't think that day's going to come. But I do know what I see, and what I see is a halfway house that I think once upon a time was predominantly people who were addicted to alcohol, probably between 50 and 70% of the people who live there, the residents who live, were addicted to alcohol. Now I think you're seeing probably the opposite. At least 75% of the people who live in halfway house right now are addicted to opiates for sure. And it's an interesting thing to see over time, because the story for everybody, even though every single person is different, the story for most people seems to be pretty similar. It seems to start out with, you know, I don't even want to say some level of dysfunction, but I mean, even to the point where, you know, oh yeah, I was younger, you know, I was hanging out at a party, I was having a few beers, and somebody just said, take one of these, and I didn't think anything of it. Took one of those, and, you know, did it a few times here, a few times there. Next thing you know, I couldn't stop taking those. And that's a pretty consistent story that I've seen over time. And whether it came about through that or through, you know, an injury, an emergency room visit, whatever it is, you know, it is definitely spread out to the point where it's out of control. And I think for people who maybe aren't as kind of in the trenches as I think some of us are, you may say, well, how in the world do you go from, you know, pills to putting a needle in your arm? How does that transition even happen? And I think it's something that comes down to, you know, unfortunately, money. I mean, if you're taking pills, your prescribed pills, I mean, sooner or later your doctor says, okay, that's the last script, we're all done with this, and then you go to this guy who's got it, and this guy says we don't have any, but I got one pill, you got $80 for that, and $80, what the heck? No, I don't have $80 for that. And then guy B comes along and says, man, just give this a shot right here, it's the same thing, costs you $10. And $10 sounds a lot better than 80, and it just progresses from there. And that's kind of where that transition starts to happen. It is a tragedy. It's a horrible thing. I think one of the things that addiction does to people is it absolutely destroys your name as a person. When you emerge from this thing, your character is shot. Your family members don't trust you. The legal system is tired of you. Your friends are all in the game as well, and you're pretty alone, and you have quite the bad reputation at that point. So I think getting in position to reestablish yourself as a person is a very hard thing to do. I think addiction drags us through the mud for so long that when we emerge, we are covered in mud, and people don't know what to think of us. They don't know how to trust you. They don't know how to, you know, give you a second chance or how that goes. And so I think at the Maxwell House, what we do is we work closely with Family Counseling Services, or our outpatient provider down the street, and our guys are encouraged to start their lives over again. One of the things I saw when I was in Liverpool and working with a lot of people who were in the Syracuse area is that they were coming in, they were addicted, and they just would be leaving at the end of the evening. Maybe they were, you know, screening negative, nothing in their urine, but they were going home to a house where half the people are using. Or if no one in their house is using, half the people in their block are using. And it's like, how am I going to make it through tonight? That's kind of where a place like the Maxwell House comes into play. Maxwell House gives people the chance to step outside of that environment that can be so toxic at times, and really kind of hit the reset button on their lives. You can come on in, you can start over, you can do this thing, and you can learn about exactly what it is that's going on and what you're going to need to do things differently. It's not easy, obviously. I'm sure taking into account those amount of things that happen to you when you're out there and you are using. It's not an easy road to start to develop a new name again. But I don't think there's anything in life that's worth anything that isn't easy to get to. So I think with really good outpatient treatment and with really good guidance along the way, people can really be encouraged to say, no, there's definitely a chance. There's a huge chance, and it's only you who's going to make the decision as to which direction you're going to go. And I think I'm glad to see one of my coworkers is here tonight, and with people who are living examples of what this is all about. I mean, the proof is in the pudding. I think a lot of times when you get clean, you have a hard time of even believing that people around you can do this. You're just getting out of inpatient, you're coming to Maxwell House, and you're like, no one knows my story, no one's been where I've been, nobody knows how this can't be done. But when you get into a program and you have people who are there, who have been there, and who are no longer there, and who are actually on the complete other side of the coin, I think that gives a lot of incentive and motivation to do this thing. And I really just try and encourage a lot of the guys we work with to really kind of get on their horse and really start the process of finding out how to build character as a sober person. Obviously not an easy task, but at the same time very doable, and the more people we have, we like to have a lot of people who've come through our program, who have done well, and who are now active in the community and trying to bring awareness to it. We love to have them come and speak at the house, and we love to have them kind of shepherd the younger guys to these things, these channels that do work. I think we're always invested in seeing the numbers of people who succeed go up. We're always trying to find new ways to do that. Obviously, we're also governed by the Office of Alcohol and Substance Abuse Services, OASIS, and so finances is always limited for I think facilities like ourselves. But I think as we do start to have more forums like this, as we do start to have an open discussion about it, I think money. It sounds like a crazy thing, but I think money becomes less of an issue. Because the more informed and the more invested a community is in really finding out what this is about, the more addiction starts to get put on its back. And it's a horrible thing to see communities completely on their back trying to get this thing off of it. And I think right now, Oneida's at a spot where we're starting to really see this thing creep in, and it's like, okay, well let's get aware right now. Let's get serious about what we need to do, and let's put this thing on its back before it gets on us first. And I would really encourage if there are people here who are family members of people who are addicted, I would really encourage not just the family members to be seeking out, their own help to deal with the tragedy of addiction and the nastiness that it involves. I would encourage family members, if you do have people, your family members who are also addicted, but they're in the recovery process, have them come to meetings like this. Because, I think we have 50-something guys in our multiple programs that we oversee at Liberty Resources. I encouraged every guy in the program to be here tonight. And as I'm looking around, I don't see one. And so there's a reason for that. There's a very strong degree of shame and guilt of sitting in a room and saying, yup, that's me. I was there, I did that too. And it's embarrassing. And no one likes to do that. But that is how we put this thing on its back. In my opinion, I think it's a huge piece of the puzzle that needs to start to change around. I think people need to get involved. People need to encourage people who are in recovery, people who are doing things differently, to be at events like this, to be at the Maxwell House talking to guys who are trying to get it right. And I thank God for the guys who have come through the program and who have come back and who have really kind of shined the light for some of these guys who just don't have much hope, who don't know what's going on. I know there was a gentleman who was I was hoping he could come tonight, but he had another engagement, and I wanted to kind of, see if maybe he wanted to talk about it. But it's guys like this one individual, it's peers that I work with that really can start to motivate these younger guys to be involved, because it's not something that happens overnight. You don't undo half of your life worth of destroying your name in 6 months. It just doesn't happen like that. So I thank everybody for being here, and like I said, I would really encourage you guys to talk to family members and encourage people who are in recovery to speak up and get vocal about it, because we just don't want this thing to get any nastier than it already is. We just don't. So, next one.
Thank you very much.
Absolutely.
Next, Chief Paul Tomsky.
Thanks, Rick, and thanks everybody for being here. I think Rick probably would have sounded a little more organized if you started at this end of the table. Pick through some of my notes here, because I don't want to repeat a lot of what's been said. The problem in Oneida, as everybody has said, is not insignificant. But it's not insignificant anywhere else either. Sometimes it may even seem like it's more significant here because we really take on a proactive approach to dealing with the problem on a law enforcement basis. I was born and raised here, and I recall as I was probably a senior in high school, there was a rumor going around the school that one of our classmates had gone up to Syracuse and had purchased cocaine. And that was shocking to everybody, as well as should have been. But that substance, along with all of these other substances that we're talking about, was not readily available in downtown Oneida like it is today. I'm sure that there are people that could go to multiple locations within several blocks of here and purchase about any sort of illegal substance that they cared to purchase. So, again, and this is kind of a little bit of repeating, but the things that we hear, at least anecdotally, which cause people to fall into addiction are the addiction to pain meds. And once somebody starts one of these drugs, tries heroin for the first time, and they get such a rush or such a high from it that they are continually trying to achieve that first high that they first experienced. And that's where the fentanyl comes in, I think, where the drug gets mixed with even more powerful drugs to try and achieve that same high for the end user. So from a law enforcement perspective, we have one full-time investigator out of a staff of 23 people that deals exclusively with this drug problem, and he gets support as he needs it, as he's involved in, an investigation from other investigators within our department, and we're talking with Sheriff Hood about combining resources. He has some people full-time that are dedicated to this problem as well. Last year, we experienced 4 meth labs, which was actually a low for us over the course of several years. But so far this year, we're up to 7 meth labs. And meth labs are extremely dangerous. You may have read in the media back in January that we had a meth lab explode in a multi-dwelling apartment house here in downtown. Fortunately, there were some people there that the person who was doing the cook, actually his clothes caught on fire. And he was in a room that was carpeted and the carpet caught on fire. He tore off his jacket and his shirt and took off running. Unfortunately, there were some other people in the dwelling there that put the carpet out. But that house was full of other families, children. So, just imagine the tragedy that might have befell downtown if maybe that was occurring later on at night, or if there were people there to take care of the immediate fire. Last year we had about 100 drug seizures. So every third day we're seizing some sort of drug. We are extremely active, as I said, or proactive in the enforcement of these issues. And we don't target the user so much as we target the supplier. That's people, those are the people we primarily want to get off the street. Now that's not to say that if we don't run into somebody who's in possession of heroin or some other substance that they're not going to get arrested. But we don't go out and target those people, we're targeting the suppliers, and that is a labor-intensive task. You may have just read about, late last week, that we closed out a long-standing investigation into the distribution of crack cocaine. So a different drug, but the same premises are involved in terms of investigating that. In that case, I think we opened in October last year. So, it's a 7 or 8 month process, oftentimes, to bring one of these cases to conclusion. And it's dangerous work, not only because of the people that we are dealing with, but because of the substances that are involved. As I said, with that meth lab that exploded just this past January. In fact, when we happen upon one of these meth labs, or when the Sheriff's Department happens upon one, there's a specially trained unit with the state police that come out and remediate the chemicals and the substances that are involved in that. So it's not like we just go in and out. It's a very lengthy process. Some of the kind of public safety issues, you may have seen this yourself. We frequently get calls of discarded needles, especially in the downtown area around the park. None of us want our children to be out and about and happen on one of these needles or step on one or.
I've come across two in the past week.
I found one and I took it to a shop center and I called the police to report that I found one in the
So that's one of the public safety risks that come with improperly disposed needles. We also just, this past week, had a person who was high on something who was out in the middle of Route 5 up by 5 Corners and nearly got hit. And so he's certainly a danger to himself. He's a danger to motorists who are driving through that area. He's a problem for us. So the issues are wide-ranging, and let's see. Also, of course, as has been mentioned, it's a drain on EMS resources when folks are in an overdose situation. And I know I think the judge mentioned that oftentimes folks are engaged in larceny type activity to support this habit. We've had larcenies of prescription drugs. We've had people report prescription drugs stolen from their own vehicles, which oftentimes is just a ruse, I think, to get a police report, to go back to the doctor and say, oh, my drugs were stolen. Anymore, right? And then there is quite a network around the Rome, Utica, Oneida area that go to a predominant department store. I really don't want to name them, but they go around to all these chain department stores and they steal items that they have black markets for. A lot of the energy drinks, get a good return on the value. So they might get 30 or 40 or 50 cents on the dollar for these energy drinks. Baby formula is a big one. If you ever go to a store now, you oftentimes see that baby formula is locked up because it's a prime target for thieves. And of course, any of the electronic items are a attraction. I arrested myself a guy some years ago who had gone around to all the supermarkets and had stolen all sorts of meat, steaks, and that sort of stuff. And he told me he had like a mom and pop restaurant, Pub and Grill or whatever it was, that was paying 50 cents on the dollar for any sort of steaks or meats or whatever they brought in. So
you very much, Chief. And now, Dr. O'Fonnell.
First and foremost, thank you for inviting me here. A bit intimidating, but I'll do the best I can do. I think it's important for me to be here today because a lot of times we talk about opioid epidemic and no one really mentions the accountability of the physician. In light of healthcare, we are committed to addressing this issue, and so it's a fact that the number of prescriptions sold in the United States have increased since 1999, quadrupled. It's a fact that ER visits for non-medical issues for opioid use has increased from 1999 to 183%. Sorry, 2011 to 183%. It's a fact. It's a fact that prescriptions are written by providers like myself. So professionally, I'm responsible for dealing with acute pain as any other physician is responsible for. I think the issue that I see is when you make a decision to write a narcotic prescription for a patient, are you really thinking about the accountability when you make that decision? Are you making the right decision about the number of prescriptions you write for a patient or a number of tablets? And so in Oneida Healthcare, we saw there's an opportunity to look into what are we doing wrong, or what opportunities can we address this issue for Oneida County, Madison County, and Oneida of this overuse of opioid use and abuse. So what I did was I looked at a study done in Colorado by the American College of Emergency Physicians, and the study looked at the number of prescriptions prescribed and why it's administered. And so I paralleled the same study here in Oneida at the hospital. And so what I did was that Oneida, we asked our IT people to look into our electronic health records and get any prescription that was written out, the provider who wrote the prescription, how many tabs were attached to that prescription, and each diagnosis that was attached to that prescription. And what I was able to find was that I was able to look at different musculoskeletal pain, chest pain, abdominal pain, kidney pain, for any diagnosis. So what I did, I broke it down to see exactly where are our opportunities. And what I learned was that it's quite astonishing. The way we prescribe is maybe contributing to the epidemic. And I say that respectfully because I think that a lot of times when a patient comes for back pain, we don't know the 1 to 10. I'm assuming it is a 10. I'm assuming that what they're telling me is true. And so when I realized that in Oneida Healthcare, for musculoskeletal pain, for back pain, 25% of prescriptions written was for back pain, 22% for muscle strain, 19% for musculoskeletal pain, neck pain, 3%. So when you look at most of the studies, there's no studies that can show you evidence-based that back pain is cured by using chronic, long-term opioids. For 2 weeks or so, yes, there's studies that show that it can help for 2 weeks. But after that, there's no study that can prove that for using Narco or hydrocodone for chronic pain is effective. It's actually more damaging. So the question that I challenge my colleagues with that is, if someone comes in with pain, who has chronic pain, is it real pain or is it withdrawal pain from the opioids? We must understand that opioids withdrawal pain is real. You can get muscle pain, joint pain, you get numbness, you get tingling. And so these are opportunities that we have in Oneida to look at and address. I also looked at pain medicine prescribed that was non-musculoskeletal, which includes renal, kidney stones, urinary tract infection, abdominal pain, dental pain, skin infections, or any type of infection, lung infections. And I found that 27% of our prescriptions prescribed in this area is from kidney issues, 27% for abdominal pain and other abdominal etiology causes, infectious diseases. So someone comes with pneumonia, they get a narcotic. Don't understand why. And so we was able to look at the way each provider specifically describes, administers these medications, and there were some outliers. And the question is, how do we deal with outliers? And so we looked at the Colorado study, and they have 5 pain pathways to alternative treatments to opioids. And we decided that we would adopt some of those treatments and educate our providers. And shockingly, a lot of people were really shocked about how we were actually doing and what we were doing. And the question is, how do you deal with an outlier? And so we came up with reduction plan, and part of the plan that we incorporated so thus far was to limit the number of prescriptions of pills. So when someone comes in for back pain, they have a pain, and they get discharged, in our electronic system, it's defaulted to 12 pills. That's the max that you can possibly give. Continue focusing on questioning why people use long-acting opioids versus short-acting opioids. Look at providers who prescribe repeatedly to the same patients. And so Oneida Healthcare is committed to addressing this issue. This is the beginning phase of this opioid reduction plan, but I did think it was important for me to show up today just to show you, that we have our eyes on this and it's very important to us. And we do want to take a big role in this epidemic in Oneida.
Thank you very much, Dr. Reed. That's important information for us to know. So, before we launch into the question and answer, and I'm sure that there have been some stimulating comments and interest in the department, I want to reiterate one more time. This forum is co-sponsored by Bridges of Madison County, by the Central Region Addiction Resource Center, and of course by the Oneida Public Library. And we're very proud to have the opportunity to serve and inform the community through this kind of activity. So it's great. So with that, do we have questions? Do we have comments from Michelle?
Well, someone mentioned that the age where people we have the most addiction is between 20 and
25 and 40.
25 to,
The opioid overdose deaths occur at that age range, between 25 and 44.
so presumably the younger people they have support systems of their parents and things that are kind of keeping an eye on them, watching what they're doing. Maybe it's less,
It's more the clock.
it's more the what?
It's more the clock. If you start your opiates at age 18, one of the problems with the opiates is a person builds tolerance and needs higher dose in order to achieve the effect. But as the tolerance is increasing, the lethal dose does not increase at the same rate. And so as their tolerance increases, they're getting closer and closer with their normal dose to a lethal dose. And so by age 25, they've been in the game long enough now that they're at greater risk for finding themselves in an accidental situation. And that, every case is unique and individual. There's no lockstep or speed at which people would progress in terms of their addiction. But the biggest issue is the length of time in the game. And then over time, it's exposure to stronger drugs. Chief Thompson was talking about the risk when you go into a home and you're going through a substance. Fentanyl, pure fentanyl, is so strong that you can absorb a lethal dose through your skin. Okay, so a police officer checking out this powder, if that officer isn't very careful, they could put themselves in real jeopardy. And so, as the cocktails that are being made available to people over a period of time, and there's no consumer service that's doing the review of the ingredients or guarantee of the ingredients. So the longer you're in the game, ultimately you're going to have the risk for having a lethal experience.
So then I would say the element where we're talking to people before that age, where they're starting, say, at 18 or so, is there still that strong, there used to be, like a strong, emphasis on getting people before they start. And are we still strong in that? Is that still happening?
Well, I can just speak to, we do a program in the schools, middle schools, called Life Skills, and they've just developed, thankfully, a unit on opiates and on about prevention, so talking with young people. And then the other piece, we've all touched on it, is for consumers and parents to become more savvy about asking questions of their physician to say, do I really need, we have a sheet here, 12 questions to ask for if an opiate is about to be prescribed, to see if your child sprains their ankle in football or has a root canal. do I need to take this painkiller, or can I take Tylenol? So being really those kinds of things in terms of prevention of helping people not to start in the first place and end up in a dangerous road.
I just want to comment as a mom. Middle school, the stigma just isn't there anymore. I was talking to my middle schooler a couple of weeks ago about Juuls, which is nicotine from vaping. And it's very common. It's, you know, he knows the kids that are using it. It's not, there is not a negative stigma the way there might have been when we were in school. You know, when I was in school, pot was such a big deal. Today, these kids have access and try stuff that would shock most of us if we sat down and had to talk about it. And I think that's the scary thing that's different with my 13-year-old now versus my 30-year-old. They weren't exposed to it the way my kids are.
Allison?
I've been to several forums and a lot of informational things about the opioid crisis and things that are going on, and things that we're doing well, things that are not so well. And I just wanted to touch on the fact that I think that the doctors that we have that will treat the people who have the addictions, I don't think we have enough of them. And the ones that we do have, apparently they can only have 100 patients. So therefore, they're overworked and don't know which ends up anymore. And then they get these kids who are either court-ordered or decided to quit and have tried to get help, and there are no doctors. Then on top of that, then if they do have a doctor, the doctor gets them on medications to get them through this crisis where they're trying to get off and they are going through withdrawals. So they get them on Suboxone. Well, then the Suboxone, I don't know how it all happened, but Suboxone is not, and Xanax have been given at the same time. And so that the post addiction is almost as bad as the addiction, because then they don't get off the Suboxone. And then they put them on Xanax to keep them calm about it. And it's a big jumble. There's just so many things that need to be straightened out with what the treatment is, how long it should be, how to get off this, don't do this and this together, things like that. And then the number of doctors we have, I wish we could get more. I've spoken to find out how just a regular GP can get that part of it where you can take care of patients who have been the addicts. And apparently it's an 8-hour course for an MD. So I always wonder why they're not just jumping on it to help this crisis, because everybody knows we are in deep doo-doo. You know, it's not a good situation. There's so many kids out there that are really in need. And then also the other thing is the court mandated ones. I think those kids are doing really much, much better off than the ones that have not been caught or have not done anything, but are addicts. So they want to go into rehab, but guess what? They smoke cigarettes. And they're not going to give up their cigarettes and their drug at the same time. Because now, most places that are treatment centers will not take anybody that smokes. So now you're giving them a double whammy. They want to get off that bad drug so bad, but yet they're not willing to give up their cigarettes, which I think that's kind of counterproductive for the state or the counties or whoever has said we're not going to have smoking on campus. That's the double whammy for these kids who really need to get off the drug, and they're not so worried about the cigarettes. They can quit those later. But they can't do it, so they're not going to treatment. They'd rather stay out here and try to do it on their own, and try, and try, and try, and try. You know, and some of them die. And then I had one other thing I was curious about. I've been learning about this and seeing this firsthand from my family members and things like that, and I'm frustrated. The no smoking, I thought that was sad. Oh, then, oh yeah, and do we know how many doctors there are, and if they still are only allowed to treat 100 patients? Do we even know how many doctors in Madison County or in the areas that do treat them?
I don't know that.
There's a treatment locator tab that's part of the federal government, and I know we had somebody that was looking for something in New York City, because we do try to connect around the state.
Mhm.
And in this county, No, we don't have a large number of providers in any
And we are in
discipline,
big
really.
trouble around here
But
for
if you
that.
go on, it's the Substance Abuse Mental Health Services Administration, and you can plug in, and the number of doctors is increasing, but what I'll say is it's not increasing necessarily here. But yes, they're trying to train and get as many doctors as they can. But you're right, it's still very difficult to get people into treatment in a timely fashion for a number of reasons.
And the court system, I'll tell you, the drug court, I've seen that work amazing. And it just amazes me that how well that works. And I applaud you guys for that, I
Well,
really
thank you.
do.
We have a lot of challenges that come with that. I
Oh,
mean,
I bet.
we like to recognize, the addict himself isn't the only victim. You've got parents, you've got children, you've got spouses, you've got significant others. They all get swept up in this.
Mhm.
When we get people that get accepted to our family treatment program, it's not just stay clean. They've got to go to family counseling. They may have to go to anger management, because then they've got a component. They may have to go to parenting class. Then they've also got to hold down a job. And oh, by the way, they live down in the southern part of the county, like in Georgetown, where there's no public transportation at all. How are they supposed to get up here for this?
Right, right.
So these
There are
problems
wicked
just
challenges,
compound
I
and
see it,
snowball. And it's tough, it really is. So, I mean, the folks that go through the program, my hat's off to them. I mean, we've had some people who've just done terrific work. I mean, people I'll remember to my dying day. And then we have people that are just plain pathetic, and pretty much everything in between.
Well, I have one who's clean 6 years, has a baby, a house, and has a job full-time for the last 6 years.
This
So,
story-
and he came through your court system.
Now, this young lady wasn't in our family treatment program. This was a young lady that applied for acceptance into the judicial diversion program. She was not accepted. She was one of three. Chief Thompson would recognize the name if I said it. She was arrested in Oneida for selling cocaine. I sent her off to Willard this morning. 2 years determinate, followed by 2 years of post-release, but sentenced directly to Willard. She'll do her 90 days. She'll come out. She'll have the better part of 3.5 years to go. But she's a single mom. She has 2 kids. If it weren't for the fact that her mother is willing to take these kids while she's at Willard, they would have had to go into foster care, which means the county taxpayers through the Department of Social Services have to pick up that tab.
Right.
So these things don't exist in little isolated pockets. They spread out, and it just brings a lot of things in its wake. But with the family treatment program, we can't help everybody, but every once in a while we get lucky.
Right.
You coming here?
Oh, I was just gonna say, on average, they say a parent, it's different in different counties. A parent gets their children taken away through CPS, and they go to rehab and they start doing what they're supposed to be doing. And they complete all that. And I know it's generalized in the time period, but in different counties. But what do you see on average, like how if they do what they're supposed to do and everything? On the average, what's that time period that they would get their children back? They completed all their.
Okay, I can't break this down for you in terms of what's opioids, or what's the filthy house, or what's the domestic violence, but just neglect generally. And I'm going to take out child abuse cases. They're much more serious, but child neglect.
Like neglect.
Okay, so with a neglect case, in those instances where the children have to be removed, it doesn't always happen. Sometimes the parent realizes the problem and can address it immediately. In that case, we don't have to remove the kids, or actually the social services department does that. When they do have to be removed, the social services department is obligated to try to find a responsible family member, a grandparent, an aunt or an uncle, somebody like that.
Yes, they did.
If they are unable to do that, the last recourse is foster care. Now, if a child goes into foster care, because the federal government pays part of the cost of foster care, they have some skin in the game. They want to have some say about this. So there is some legislation called ASFA, which is the American Safe Families Act, which says if a child is in foster care for any 15 months out of a 22 consecutive month period, that amount of time, The social services department, at the end of the 22 months, or the 15 months, whichever it happens to be, they are obligated to bring what is called a TPR, a termination of parental rights, which is a pretty dramatic thing. Fortunately, I don't think in Madison County we see maybe more than 4 or 5 of those a year.
You see,
What will typically happen is once they bring it, in most cases, the parent will wake up and pull out of the tailspin and start getting serious about recovery. Sometimes the parent will sign a judicial surrender, just raise the white flag and agree that the child will be free for adoption.
if you see,
And sometimes we just have to go to a fact-finding hearing and do a trial.
right, if you've seen, say they went to a family member, but they lost their kids and they charged neglect with a family member of mine. They went to another family member, not in foster care, 3 kids, but, then, you know, she's getting clean and treatment and everything. I know in different counties, she's in a different county, but, another county, but like, the general, if they do everything right, they go through all, like say they go through your program. I was just kind of wondering, what is, I don't know if you could tell me, like the general, time period where they usually have to go and take all these classes, and then they get their kids back in what is it, like, service value, if they don't do that, then about the parental rights being taken away permanently?
Well, the rule of thumb is, in cases where the children are not in foster care, so we don't have that 15 out of 22 months thing hanging over your head. If they're placed with a family member, social services usually likes to see the case resolved within a year. So the parents have that amount of time. Now, if need be, if somebody doesn't have it quite done yet, they'll extend it, maybe another year, and try to get it resolved. But the last resort, obviously, is the TPR. Sometimes what will happen is if the grandpa, let's say it's grandma and grandpa who have the child, the 8th, and they just realize that mom is never coming back. It's just not going to happen. So with mom's consent, we'll place custody with grandma and grandpa. And, you know, social services just figures we've done everything we can do.
Right,
And again, sometimes it's drug related, sometimes it's got nothing to do with drugs, it's just other things.
it does, but yeah, like, this, but, okay, thank you.
If you're asking about how long is a person typically in treatment court, which is one of the specific things, then as you were saying, every county is got some of its own unique features and so, but
Right.
most of them are built on a person goes through the program by making incremental improvements. And the speed that they could do that, they may be finished in less than a year, or it may take them 18 months to get through all of those, depending upon how complicated their lives are, how successful they are. So there's a pretty broad range within those organized, treatment court programs, independent of, as Judge McDermott's laying out the background.
Right.
That clock's running all the time, whether they're in the family treatment court or
Because I
not.
don't know if it was like a 2 or 3 month period, like that small of a period, but it might usually probably like a year period.
But typically, it's much
It's
longer.
like,
Peter?
At the national level, in the National Institute of Drug Abuse shows a relapse rate for opioid addiction of at least 40 to 60%. There's some other studies out there that show anywhere from 72 and higher. But those are national. Any idea what the relapse rate is in Greater Central New York or upstate New York?
I can take a shot at it, but I don't want to. What upstate New York is really not significantly different than the national averages, because you're dealing with essentially a physical phenomenon more so than anything else. If you look at the relapse rate from nicotine, it's a higher percentage than it is for opiates. So Opiates are very addictive and very dangerous, but they're not necessarily the most addictive drug. And most people who successfully quit smoking make, I think they estimate now, 7 or 8 attempts before they are finally able to, to stay off smoking. And it's a similar number for treatment attempts. So people relapse, but that should be recognized as really part of an ongoing process, that they make some progress, maybe they fall back. And frankly, it's no different than people managing diabetes or managing hypertension. Any of these long-term chronic disorders that require significant lifestyle changes, people don't go in a straight line, typically. And they need multiple attempts to ultimately be successful. The key thing that is still substantially lacking in much of New York and much across the country, treatment is still being delivered with a similar concept to, if you break your leg, you go to the emergency room and you have your leg set in a cast, and you're going to be in the cast for a period of time, and then there may be a period of short-term rehab to help you recover your balance, your walking skills, and that sort of thing. But the thought is that somewhere shortly down the road, you're finished with it. You broke your leg, now it's taken care of. Addiction is a lifetime disorder. And what's missing more than anything else is substantial recovery supports that are designed to help really make people more successful in their recovery after they've had treatment.
I wanted to follow up with something that Dr. Reed said. I remember a time when there was great resistance on the part of physicians to prescribe serious pain medicine, including people who were terminally ill with cancer in terrible pain. And I was involved in a situation where a physician said, I'm not going to prescribe whatever it was, I think it was morphine. I'm afraid he might be addicted to it. Well, this person was in terminal. It was in a terminal situation, literally going to die within weeks, a few weeks. And the doctor was concerned that at that time, the modus operandi was to be very restricted in giving those medicines. The pendulum definitely swung the other way, became very, very liberal. The good news is, as Dr. Reed related, the electronic medical record and the collection of medical records, electronic medical records among providers, and I forget what the name of the Central New York Code is. There's big data is out there. They're collecting this data. They can pinpoint things. They can identify doctors who are prescribing more or less, figure out what the best practices are, and make some real progress with that.
And the patient jumper. Patient who goes from doctor to doctor to doctor.
Well, there is a slight erosion in privacy because the big electronic medical record is going to know everything about your medical situation.
Well,
but this is heroin or opioids is not a new problem.
Right.
When it was restricted to a few of the inner cities back in the 40s and the 50s and the early 60s, it was a problem, but it didn't have a lot of attention. A lot of people came back from the Vietnam War addicted to heroin. And I actually worked for Congressman James Hanley in his Washington office. In 1972, I worked a file for a soldier who was the son of a constituent of Mr. Hanley's, who was in the Army, and the Army did not deal with him the way the regulations said, 1972. I'm not sure we've made as much progress in that 46 odd years or the 50 or 60 years, but I think we're getting to the point where we're getting enough data together and seeing what does and does not work. That I have hope. It's not faith at this point, but it's hope that we're going to come up with better treatment systems that work. And part of that may result from what's happening in healthcare, where there's a push towards population health, where the risk of cost is being shifted to the hospitals and to the doctors. And they are being pressured by the government to take into account more long-term promotion of good health, prevention of problems, primary care, not waiting until the broken leg has occurred, although you can't anticipate the broken leg, but addressing issues before they get to where they are life-threatening and really expensive. And I think that some of that is going to transfer over into the behavioral health segment of healthcare, and in particular, the dealing with the substance abuse. But it's a huge problem. The dollars, the cost for behavioral health is extremely high. And the reality is, if a lot of resources are shifted to that, they're going to be coming from other places in the healthcare equation.
Peter, this is dated information, so I'll acknowledge it's a little bit dated, but back in the 80s, there was a significant increase in outpatient treatment resources. New York's legislation changed, and so it became easier to set up outpatient clinics. And Blue Cross Blue Shield took a look at their payout for substance use treatment. And outpatient treatment constituted 0.2% of their payout for outpatient services in 1987, I think. Where other studies have shown that as many as 25% of people in a typical medical practice have addiction or alcohol-related problems that aren't being addressed by the provider. So the cost of not treating it is way more expensive than that cost for treating it, even if we're going to double or triple the budget that we have for treatment. We're still spending way more not treating it.
And can I just say-
Gary? I'm sorry, Susan.
I was just going to say, I think we're looking at, things used to be very standardized, what treatment would look like, how many days you got, dictated by the insurance companies. And I think one of the bright spots for Faith or Hope is that there's more emphasis on peer support. They have people that will go meet with people at libraries, that will have a mobile van, that will go to people. So rather than waiting for people to show up in the office or show up in the ER, trying to say, we need to go to people where they are and meet them at the library or some Burger King or wherever. So I think there's some things that are changing, as you mentioned, that we needed to change and that we are trying and that are successful. So a peer, working with a peer, is, like you were saying, Jim, it's very, very powerful. So it hasn't changed things a lot yet, but I think a lot of these things are new and they're up and coming, and I think we can see more success with that as well.
Thanks, sir. Now, Gary.
James, you said there was about 50, 60 people in your program, 75% on opiates. You hear their backstories. Are they getting addicted when they're like in high school, 16, 17, 18 years old? Is that a typical place where they're doing this, or are they getting it post high school down the road somewhere because of some other reason? And I'll explain why.
I think it changes from person to person. It really is individualized. I agree with what she was saying over here before about the stigma in terms of younger children and the stigma. I mean, it's one thing when you're 16 and you're at a party and you've had a few beers and stuff, and someone says, well, here, smoke this or do this, kind of like, oh, I don't know. Someone says take a pill, it doesn't taste like anything, doesn't look like anything, you don't see it, it's gone. And then you feel times 1,000. And so, whereas once upon a time, there were actually some barriers. I mean, even alcohol itself, I can remember being younger, I mean, the taste was repugnant. It wasn't something I was like, ooh, that's so good. It was like, choke it down. When someone take this pill, take that. There's no difficulty taking that. And that happens over the course of a few different times. Next thing you know, it's like, well, yeah, I want to feel like that. I can have a few beers and feel like this, or I can have a pill and feel like this.
What I was really getting at, and the reason why I asked the question, I was a high school teacher, and I can't tell you how many people, how many students of mine would come in with knee problems, tendon problems, shoulder problems, playing sports, playing football, lacrosse, tennis, you name it. And they would be in the classroom for 6-8 weeks in a cast or whatever, going to a physician and getting pain medication. And the reason why I asked the question was, are we starting these problems in high school? Through some of the things that we have accepted as normal high school activities, and yet they manifest themselves down the road into an addiction problem because of pain. Basically, that they start at an early age and have these pain problems. Because I was a high school teacher, you see it all the time, the party, just what you were talking about, going to a party. And that's where all the other addiction things, smoking, drinking, the common drugs, that all starts there through peer pressure. But we're talking about opiates here, so I'm wondering if we're starting this problem in the high schools through these sports injuries, and then they manifest themselves down the road because they got tolerant to it, and then they end up having problems in their 20s, 30s, 40s, as you're starting to see. And so I just wondered if you saw that with your patients, since you see a number of patients and you know their backstories, if that's where they're maybe starting. Of course, there's other things that attribute to that, but if that's where they're starting their problem.
I would say a percentage of it. I can't necessarily speak for the whole, but I definitely think a percentage of it is caught up in that realm for sure. And I do think, and again, a lot of societal things have changed over time, in terms of, pain management in general. Pain, when I was younger, I was taught that pain was something that told you something. If I'm hurting, it tells me, man, you got something going on there. You need to get that looked at. It needs to be fixed. And I think that pain in general is looked at as something that, well, we need to get rid of pain. We need to get rid of pain. So it's almost like the emphasis has shifted towards alleviating the symptom as opposed to the actual problem, which is definitely a detriment. There's no question about that. I mean, that's something that, personally, I've always been a fan of, I don't want to say fan of pain, but I've been a fan of knowing when I'm in pain. If I don't know when I'm in pain, I can't get better. And when I was an athlete and I was younger, if I can't get better, I can't play because it hurts and I can't do what I want to do. I don't, again, my kids are a little bit younger, so they're not of that age yet where I'm actually can't wait to experience those days. But, so I don't really know firsthand right now what it's like in the schools for a teenage, child. But I can imagine, and I do think, again, I would really emphasize, I haven't even looked them over, but they're probably like gold, the 12 questions right here for parents to ask, because, to be aware of exactly where your children are at, what their understanding of pain really is, just to be aware of what the signs might be that this is going on, because it's quiet. People who are addicted, people who are severely addicted to opiates aren't really taking opiates and it's like, wow, look how high this person is in opiates. People who are further along in their addiction, when they take opiates, you don't see anything. They feel normal now. They feel good right now. Like, I feel okay and I can go to this forum and I can talk and I can be like this and that. But the thing is that there's a pain component of opioid addiction. There's this physical component, this withdrawal component, I know you're talking about, Doctor, before, that is such a strange thing, I think, to the world of addiction, that when someone is prescribed a medication that alleviates the pain associated with withdrawal, a lot of people think, I'm better now. When in reality, if I've been using opiates for 15 years, I am far from better. I'm not close to better.
Well, I'm just trying to figure out where it started.
Sure.
There's
a million different factors.
I'm going to ask us to wrap it up here.
But that's where I was getting at.
We promised to be here for an hour and a half.
We can talk more after a few.
And I want to thank the panel members.
This lady had a question, she's been very patient.
She's been patient and waiting. Okay, so we'll make this the last response.
Could you make it the last question?
Wait, I'm Charlene. I am a recovering addict. I've been sober.
Hi, Charlene.
And great to be living in this world, clean and sober for the last 28 years.
Congratulations.
And I appreciate the fact that you have this community meeting. I just wanted to commend you all and thank you all for being involved You know, I mean, it's very good to know. I just came from North Carolina. I've been down there for the last 10 years. And a lot of the girls that I sponsored went through this drug court thing. But before I went down there, I knew nothing about a drug court. So that is a good thing. I'm hearing that, you know, things are really, you know, people are really stepping up and trying to help the addicts, you know. And, you know, and that halfway houses, man, I hope they just keep on coming, because the main thing
Hope
is,
so
you know,
too.
keeping away from who they're active with. I'm so happy to hear that you're in this group too. All of you, I really commend you for that. Because we do need a lot of people that have the compassion that you all are showing me today. And I appreciate that. Thank you.
Okay, that's, some of the panel members are going to be here for question and answer. Sheriff Hood is here.
I'll say one thing quick. You guys are all here for a reason. It's a great reason. One thing I can say is, go do what you do. We enforce the laws of the state of New York. You tell me where a drug house is, and I'll get a team together, and we'll do search warrants, and I'm sure Chief Thompson will also. If you are someone to rehabilitate, do the best you can. Doc, you know what's going on with everything in the hospital. Spread the word, preach the word, and reach out to the people in your groups, because collectively we're going to solve this. Not one person in here is going to take care of this. From what I've seen, I've been dealing with this my whole career with the opioids, and I've seen what it spirals into. So get in your own groups and do exactly what you do, and you're all passionate or you wouldn't be here. So I just wanted to say that. Thank you.
Thanks.
And you give us info at our sheriff's department or Oneida City PD, and we'll be on it. We'll put people on the case.